Doctors in the
Not in, no, sir. Not in Tumkur. We don't have, we have 7 doctors in the family, but everyone is in Bangalore.
Okay. Aruna? Arun?
Dr. Shivani, Shivani, please start.
Yeah.
Now we are live.
Yeah.
Shilpa, it's not from Ksoga office, huh? It's, host is not Arun, huh?
ಇಲ್ಲ ಸರ್ ಇದು ಕೋರ್ ಕನೆಕ್ಟ್.
ಓಕೆ. ಅಲ್ಲ ಯಾಕಿಲ್ಲ ಅದರಲ್ಲಿ ಪ್ರೇಯರ್ ಇದೆ, ಕಸುಗ ಪ್ರೇಯರ್ ಎನಿ ಪ್ರೇಯರ್ ಅಂತ ಅದಕ್ಕೆ
ಇದೆ ಸರ್, ಪ್ರೇಯರ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಪ್ರೇಯರ್ ಇದೆ.
Yes, sir. Should we start, Dr. Durgadas?
Yes.
Thank you.
Okay. Good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies Limited, I, Shivani Bhabra, welcome you all for the Core Connect live webinar in association with Ksoga Art Infertility and Reproductive Endocrinology Committee. So first, I would like to introduce
425.
Anuradha ma'am. So welcome Anuradha ma'am.
Shivani, mute others.
Yes, ma'am. Hello, am I audible?
Yeah, very much.
So first, I would like to introduce Dr. Anuradha ma'am. So Anuradha ma'am, she is a director, Nurture Fertility Center in Bangalore and currently practicing in infertility and infertility-related endoscopy at Bangalore. So, a honorable treasurer at Karnataka chapter of ISAR 2023 to 2025. Now, I would like to hand over to Dr. Anuradha ma'am.
Good evening, everyone. Thank you so much. I would like first to introduce Dr. Seema. Do you have her CV? She's not there. She's in some meeting, so some emergency. Can you display her CV for 30 seconds, please? Yeah, Dr. Seema Pandey is president of Azamgarh Gynae Society and librarian of ISAR 2426. She's a national executive committee member of ICOG ISPAT, and she's written a lot of books, and she is very much interested in academics. My second convener of the day is our own Dr. Shilpa. Dr. Shilpa Harish, welcome. She is a senior consultant IVF specialist, gynecologist, Sattvam Fertility and IVF Center, Rajshri Foundation Hospital and Rainbow Hospital. She is our chairperson of ART and Infertility Committee and Reproductive Endocrinology, Ksoga. And her area of interest is IVF, PCO, and poor ovarian reserve. Over to you, Dr. Shilpa. Could you please introduce the chief guest and take over from now?
Thank you, Dr. Anuradha. Good evening, everyone. Today we are launching our first webinar series from Ksoga. Can you hear me?
Yeah, we can hear you.
ART Infertility and Reproductive Endocrinology Committee 2025-27. Thank you, Dr. Durgadas, Dr. Shobha Gudi, our President, Dr. Durgadas, and Secretary, Dr. Shobha Gudi from Ksoga. I want to read out the CV of Durgadas, sir. Sir is President Ksoga. He is member of IMS, member of SOPAP, past President, Tumkur Society of OBG, Associate Professor in Sri Siddhartha Medical College, Tumkur, consultant in Kasturba Hospital, Tumkur. Sir is a very efficient vaginal surgeon. He has some more than 35,000 vaginal surgeries into his credit. He's very passionate about academics and spreading knowledge. Can I read out a CV of Dr. Shobha Gudi, our Secretary of Ksoga? Yeah. Shobha Gudi, madam, is MD DNB from CIMP. She is HOD St. Philomena's Hospital, postgraduate teacher and examiner, assessor GOI project Lakshya, president BMS 2022-23. His peer reviewer Joji and Ejor, national corresponding editor Joji, board member FPI, chairperson Contraception and Reproductive Health ESOPA, chairperson Endocrine Committee IMS, South Zone Coordinator SBSI. She is a distinguished DNB teacher, Best Society BSUG at Ksoga 2018. She is MS signature for unparalleled contribution 2020. So with this introduction, can we have inauguration? Arun?
I think we could not hear the prayer. I don't know. I didn't hear.
I know.
Call Varun. Arun phone ಮಾಡಿ.
Dr. Shilpa will invite Dr. Nirmala.
Okay. We are starting with our first topic, the ever-changing endometrium. Embryo implantation involves intimate interaction between competent blastocyst and a receptive uterus in a limited period of time, that is window of implantation. As we all know, 20% of our infertility is caused by endometrial factors. Today, we will hear from our experts how we can improve our success rates as the webinar unfolds. I would like to introduce Dr. Nirmala. Arun, can I have Madam CV? Madam is talking about how to improve endometrial receptivity in ART. Arun, can I have Dr. Nirmala's CV? Madam is treating infertile couples for more than 30 years, handled more than 15,000 infertile couples and greater than 6,000 babies born through her fertility treatments. She adds to her credit Karnataka First Test Tube Baby Center, who gave first vitrification, rapid freezing of embryo baby in 2007. Presented numerous scientific presentations at national and international conferences and contributed chapters to medical books. She also received various prestigious awards. Aribata Award from Karnataka, April 2007 for excellent service in medical field. Karunada Siri Award, February 2007. Vidya Ratna Award, 2009. Legendary Award of Appreciation by the Times Group, June 2019. Golden Ames Award for Excellence and Leadership in Healthcare in Field of Reproductive Medicine, January 2021. Dynergic Award for Iconic Women Leader Award, IVF in August 2022. Dronacharya Award from Indian Society of Assisted Reproduction, Jan 2024. Over to you, Madam.
Thank you, Dr. Shilpa Harish, for this lovely opportunity. Thanks to the team of Ksoga, my dear friend, Dr. Durgadas, and good evening, one and all. So just give me 2 minutes to share the slides before we start.
Can we have the CVs of the chairpersons, Arun?
Just a minute.
Our next speaker is Mrs. Dr. Rajalakshmi Valvekar. I want to read her CV too. She's MRCOG, CCT, FRM, DNB, Urogynec, FCPS, DGO, DFP, FICOG, FICHCM, FGO, MD, MBBS. Founder Chair RCOG, Indian Liaison Group, RCOG UK. Member India Steering Group, RCOG UK. Member Organ Donation Committee, IMA. Honorary Joint Secretary, IMA, Maharashtra State. Chair Child Achievers Award, IMA, Maharashtra. Fellow Reproductive Medicine and IVF, Guy's and St. Thomas Hospital, London. Research Fellow, IVF, Homerton University Hospital, London. Diploma Urogyn, Germany, and Diploma Non-Invasive Cosmetic Gynae, USA. Welcome, Dr. Rajalakshmi Valvekar.
Thank you so much for your kind introduction, ma'am.
The chairpersons for this session are Dr. Shobha Guri, whom we have already introduced, and Dr. Rekha Rajendran, who is the past president of BSOG. Dr. Nirmala, are you ready, ma'am?
No, Anuradha, because the CV of Dr. Rajalakshmi is already on the screen, I'm unable to share mine. Can you come out of that?
Shivani, can you remove that?
Yeah, now we are trying to do it. Yeah.
Okay.
Yeah, that's it. Yeah, can you see it?
Yes, madam.
All right.
Yes, ma'am. You can start, please.
Just be around if you can. Yeah. So once again, good afternoon to everybody. Yes, so one moment, let me just try to move this. Can you move this away from the screen because it's covering most of the screen? I just need that to be minimized. No, even more. Okay, that's better. Yes. So as Dr. Shilpa gave an introduction, the phenomenon of embryo implantation, it's a black box still in the human reproduction. Quite complex, multifactorial, and largely unknown from a molecular standpoint. On one hand, the embryo quality, no doubt, is of paramount significance. But on the other hand, we should not forget the endometrium is equally important. So, how do you define endometrial receptivity? The most accepted definition today, it's a period of endometrial maturation during which the trophoectoderm of the blastocyst attaches to the endometrial epithelial cells and then invades the stroma and the vasculature. It's a very limited period and time which is available for an optimum receptivity. And that is the time when there is a synchrony between the embryo's readiness to attach and the endometrial receptivity. And that's the most crucial step for implantation and a successful pregnancy. So there are so many factors that affect the receptivity. Stress, hormonal imbalances, polycystic, which is so common, uterine pathologies, endometrial thickness, and the maternal age, and we will see how they do impact. Age. Earlier, the thought was it can only affect the oocyte quality, the geneticality of the eggs, and then the embryo, which can be poor, which doesn't survive, doesn't go up to developing further, and hence the success of the cycle is low. But that is not the reason anymore. Today, endometrium also ages, and there's so much of light that has been thrown onto age-related endometrial aging, and we will see how it affects. Now, most of these findings of how maternal age affects endometrium and decreases the receptivity has stemmed from the use of the senolytic drugs. Now we will see what they are. Now, how age affects, it decreases the receptivity by changing the molecular, cellular, hormonal, and the histological levels. What happens with aging? There are a lot of senescent drugs, senescent cells. Now, whilst these cells need to be eliminated also, and if they are accumulated in a larger number, can result in something called inflammaging reaction and tissue fibrosis. Not alone that, it also affects the epigenetic and genetic expressions of the genes responsible for endometrial receptivity, and thereby it affects the chronological and epigenetic aging in the endometrium. Though the oocyte donation studies have shown a conflicting results. Advanced age definitely has a role to play. It reduces the functioning, though we need to have further research in this direction to come to a conclusion and understand the exact mechanism. And these are some of the senolytic drugs, dasatinib and quercetin, etc. Then it is a double-edged sword. So too much of senolytic drug usage and too much of targeting the senescent cells and removing them from the system also can land into defective desensitization, whilst if it is on excess, can also affect the endometrial receptivity. Stress, all of us are aware that it can increase the cortisol and then the prolactin levels and decrease the receptivity and implantation. It can affect the blood flow, the insulin sensitivity, and the receptor expression. Hormonal influence, we are all very aware, being programming ART cycles, controlled ovarian stimulation does have an impact. The supraphysiological E2 levels can disrupt the endometrial quality. And what we need to understand is they can negate the expression of the progesterone receptor and shift the window of implantation. So the changes in the E2 and P4 ratio can affect the various growth factors, the cell adhesion molecules, and all of them put together can reduce the endometrial receptivity. Though studies show conflicting results of the impact of high E2 on implantation and pregnancy rates. Clomiphene citrate is absolutely obsolete because of its anti-estrogenic effects on the receptivity. PCO, reproductive failure all along in polycystic ovary, was again thought to be because of the oocyte, the various metabolic factors, then the ovulatory disorders, the quality of the eggs, the genetic nature, because 68% of the eggs that a woman in PCO develop could be genetically abnormal, which was a very stunning revelation in one of the papers. PCO's influence on the endometrial receptivity was less. Any issues? Should I continue?
You can continue, ma'am.
Right. So the influence on endometrial receptivity was very less studied all these years.
Dr. Hema,
I
can you just
request everyone to mute. Please accept the speaker, please. Please mute.
Dr. Hema?
Shall I continue?
Yes, ma'am.
Yes, ma'am, you can
So
continue.
PCO affects the receptivity and poses unique challenges. It can alter the morphology, the gene expressions, the receptivity markers, the metabolism, and the hormones all can affect in PCO. All these are the factors which can affect the receptivity. Generally, if you see the type, the pattern of the endometrium is generally the type B or the type C secretory endometrium because of these imbalances, because of high androgen levels, and very rarely you get to see type A morphology. The thickness, of course, what is desired is above 7.5 with a good layering and a good blood flow for an optimum pregnancy to happen. Now, the different ER markers, there could be morphological markers, there could be biological markers like the abnormal expressions of the genes, the HOXA10 and 11. There could be a decrease in the leukocyte inhibiting factors. Then the role of insulin resistance, not to be forgotten, can disrupt the glucose metabolism and affect the endometrial cell functioning. And this is where they felt that there are papers which state that metformin can increase the insulin resistance and restore the endometrial receptivity to a certain extent. Now, the various hormones, there is an imbalance of estrogen and progesterone. The increase in the androgens can delay the HOXA gene activation and can also, today, there are papers which say that there is an progesterone resistance, which is linked to abnormal progesterone expression, thereby reducing the endometrial receptivity. And a lot has been spoken about polycystic ovary being an autoimmune disorder. There could be a chronic inflammatory reaction associated, a change in the various immune factors. All these can have a negative impact. Now, coming to the uterine pathologies. So, even if the endometrium is good, thick, with a good blood flow, but still, if there are uterine pathology, they can impact the endometrial receptivity through other mechanisms. And we will see how it can alter the biochemical, genetic, immunological, and the hormonal levels. Now, these are all the various conditions that can affect the receptivity and decrease implantation. If you look at adenomyosis, there is impaired decellulization, and practically it seems to be affecting everything. There is an altered expression of the genes. There is an underlying inflammation and a hyperinflammatory microenvironment in the endometrium. Progesterone resistance has been reported, an increase in the uterine contractility because of the distortion, the junctional zone alterations, immune cell imbalances, and not to forget the expression of all these adhesion molecules have reduced. Similarly, in an endometriosis, which is again very much related to adenomyosis, is an autoimmune and an inherited lifelong disorder with almost similar kind of a picture. So practically, these pathologies affect hormonal, genetic, immune mechanisms, biomarkers, and also causes some amount of anatomical disturbances. So there are recent retrospective cohort study almost on a very large number of patients, 3,503 who underwent the first blastocyst transfer, 140 had adenomyosis, and they reported a decrease in the clinical pregnancy rate and live birth rate, and increase in miscarriage, and this was in 2023. Till date, there is no RCT available about how adenomyosis negatively impacts. Interestingly, there is another cohort study of 179 patients with endometriosis, and they suggested that the optimum serum progesterone cutoff for a live birth could be somewhere around 37.1 nanogram per ml in the HRT FET cycle. So we should aim at getting that. This is to overcome the progesterone resistance that could be an underlying factor for a reduction in the endometrial receptivity, according to that study. So this is practically, if you see, it is 4 times higher levels than what you would normally expect. So this paper supports the theory of progesterone resistance being one of the factors behind decrease in the ER. Now, and then we know that one of the mechanisms that could help in improving the implantation and the success rate in adenomyosis and endometriosis is the long-term use of GnRH agonist. And how does it help? It's an immunomodulator. So GnRH agonists, or the aromatase inhibitors, they reduce the intra-endometrial estrogen levels, overcome the progesterone resistance by exogenous progesterone support. This is one way that they could correct the underlying disorder and help in improving the ER. Now, coming to fibroid, again, the belief was submucosal or intramural greater than 5 can affect pregnancy rate. The impact of even the type 3 intramural on the pregnancy rate is still controversial. But then if you look at it, fibroids can once again affect the HOXA family of the HOXA genes, which are responsible for a normal endometrial receptivity. Then the TNF alpha abnormal expressions can happen. It can affect the angiogenesis by affecting the angiogenic factors. The mechanical stress that the fibroids cause, it can get transformed into the biological signals and interfere the gene expression, as well as result in abnormal decellulization. Now, so that is about the uterine pathologies. Now, going over to the next common thing that we will discuss is about the impact of thrombophilia on the endometrial receptivity. Now, thrombophilic defect can cause thrombosis of maternal vessels, vascular impairment, defective placentation, and hence result in implantation failure. Many of the previous studies, they lacked power. So in fact, the debate over the role of thrombophilia in ART came from interventional studies wherein people had given heparin as thromboprophylaxis in patients with recurrent implantation failure. And that reported an increase in the live birth rate among carriers of a thrombophilic defect. Now, if you look at systematic literature review, there are 33 studies available with 6,092 patients, quite a good number, on thrombophilia and ART, wherein 23 evaluated the presence of APA, 5 inherited thrombophilia, and 5 both of them. Though the quality again has been reported to be poor, but when combined with the case control studies, they showed that factor V laden was more prevalent in ART failures. So it makes a sense to look at factor V laden. Prothrombin mutation and MTHR mutation, protein S, protein C, antithrombin, they are all not greatly associated with ART failure. Now, ART failures, it makes a sense that you look for factor V laden and also look for APA. Now, these are some of the recent studies. Kublan in 2021, he reported that 69% of women with RIF, so this is the special group of RIF where at least one inherited or acquired thrombophilic factor could be seen. Inherited thrombophilia due to the genetic mutation can be increased because of homozygous mutations in factor V and MTHR. Acquired thrombophilia is due to deficiencies of protein S, protein C, APS, antithrombin, etc. Now, the role in either it is acquired or it is inherited, it is still challenged. If you look at what ESHRE says in 2023, the testing is highly limited, be it in RIF or in patients with clinical, or it says that it says that you have to limit testing in the patients with RIF or patients with the clinical or a family history of thromboembolic events or in recurrent pregnancy loss, and they do not recommend it as a routine in any patient undergoing ART. Now, what are the tests for endometrial receptivity? Where are we as far as the tests and what is the rationality? There are 4 tools that are available under 5 brand names till today. Most of them are peer reviewed and commercialized. The WIN test, the ERA test, the ER MAP, bar the endometrial receptivity, the PEAK Be Ready test. The aim is to detect the window of implantation and to plan the personalized embryo transfer. Most of them are actually has been marketed as diagnostic, but they are only predictive of the window. And it only you can extrapolate and apply that in the cycle after the biopsy cycle. What they do, the ERA, it explores the expression of a large volume of genes, the 238. Amongst these 4 tests, only ERA studies 238 genes. The WIN analyzes 8. The ER map by the ERP, only 48. The Be Ready test analyzes 67. But that is the most cost-effective test till date that is available. But the major limitation of these available ER tests is lack of a precise definition of which is the suitable population. Are we going to subject any woman undergoing ART, or are we going to look at the RPL? Are we going to look at the RI? Who is this category of patients on whom we are going to apply these tests? So since till date we don't have a clarity on it, we are not able to really understand more about them. Now, coming to ERA, just a word about the recent, I know most of us have been doing it over the last 5 years, and I'll just conclude on what ERA means. So, what it is means today, in today's scenario. This is a very recent and a 5-year multicentric randomized controlled trial comparing personalized embryo transfer after the ERA, either prior to a fresh or a frozen, and patients compared with somebody who has not undergone ERA, and they found there was an increase in the cumulative live birth rate in the personalized ET, and this is Simon et al. In 2020. But there is still insufficient evidence to support a routine use of ERA in all ART patients. Now, these are the other endometrial receptivity tests. They're called the RNA sequence-based endometrial receptivity, and they use the transcriptomic biomarkers to predict the window of implantation. We still need to understand. There is one study which has been reported on the RIF and shows there is an increase in the pregnancy rate. Now, This could be the future once this is actually available to us, the uterine immunological disruption based on the RT-PCR analysis of factors and involved in the differentiation of the secretory endometrium towards the receptive state. But all these tests remain to be subjected to proper randomized control trials. Until then, let us hold our reins and be careful when we ask for these tests, because we don't know the definition, we don't know the meaning of it, and we cannot offhandedly apply them. Now, endometrial blood flow and receptivity, it is very, very critical for successful implantation. The Doppler ultrasound is a very good tool to measure it. Endometrial volume has very less predictive value. The clinically recommended as a routine to understand the blood flow assessment before embryo transfer is advanced. ESHRE add-on working group, very clearly the recommendations are that the endometrial receptivity test, don't apply them, they are not recommended. Currently available tests do not consider the full complexity. As I mentioned in the beginning, endometrial receptivity involves genes, the hormones, the inflammatory markers, the various enzymes. Then you have the genes. So it's a complex of various factors, not just one factor. So ERA tests only the genes, something else tests only the inflammatory markers. So just testing individual markers actually does not give us a comprehensive view of the endometrial optimum time for a transfer. So that is why they do not recommend at this point. Now, the peripheral blood test for the immune parameter, the uterine NK cell testing, etc., are not recommended prior to ART or even in the subgroup, the special group of the RIF patients. Now, let's look at a few slides on the special group, which is the recurrent implantation failure. And most of the time, all of us are in distress in this particular group. And then we start digging more and more into the molecular levels of both the embryo as well as the endometrium. So these are the different anatomical disorders that can affect, like the fibroids, which affect the gene expression. Adhesions can lead to thin endometrium and decrease in the receptivity. Hydrosalpinx can not only cause inflammation, various inflammatory factors. Hydrosalpinx is another condition, not just a reflux of the fluid which can come into the uterus or the fluid being embryotoxic, but it can affect expression of oxygenes. It can affect the endometrial growth factors also. So there are different ways in hydrosalpinx also. The different immunological disorders, the chronic endometritis, not to forget, because it affects 14 to 30% is the incidence that you find in RIF patients, and that can reduce ER and PR. So it is important that you try to assess, and we all know it can be assessed by hysteroscopy, histology, microbial cultures. And in chronic endometritis, there's a shift in the balance between the good and the bad cytokines, which disturb ER and the pregnancy rates. Then the dysbiotic microbiome, so much is being spoken about oxidative stress. Then the microbiomes, dysbiosis is becoming an interesting hot topic today. So that can also lead to immune activation and oxidative stress and can affect ER. So we can look at it. So these are the various approaches: the HCG, the role of endometrial injury, the PBMC, the PRP, GCSF, GH. We will just have a quick run through what literature says about these. Now, in general, if you look at 85% of the clinicians, they perform the anatomical and gynec test in RIF to rule out if there is any Asherman's, hydrosalpinx, and any of these pathologies underlying. And then the endometrial microbiome and the window of implantation is tried to understand. So reassessment of the endometrium is highly recommended. And of course, yes, the way the estrogens have been administered can also be a factor for scrutiny. If 3D ultrasound has not been performed earlier, worthwhile considering it. And if there is an abnormality, it is worth considering a hysteroscopy when you suspect something. Now, going to the platelet-rich plasma, if you look at literature, you know what it is. It is a extract, whole blood extract, removing the RBCs and the WBCs, which only concentrates the growth factors, the VEGF, TGF beta, and the PGDF. Now, it is as effective in regenerating and as an anti-inflammatory agent. 5 years ago, it was thought that yes, it could be a game changer. It was tried and to improve the refractory endometrium in IVF. Are we still there? No, we still need to wait. There have been a couple of papers which has been quite depressing, 3 RCTs and 2 non-RCTs, which showed in the year 2019 and 20 that they could improve the endometrial receptivity. And if you look at most of these papers, most of these studies, the evidence is quite weak. Even the data which has come up in the recurrent implantation failure are rather very weak. There are 2 recent RCTs and 1 non-RCT in the recurrent implantation which said there could be a significant increase in the pregnancy rate. But however, the study had no power and no definitive conclusion could be drawn. So let us wait until RCTs emerge in a larger scale before we conclude. Until then, retain it in the frame of a trial procedure. Now, as far as peripheral blood mononuclear cells, the first landmark study was in 2006, and they said that this could mimic an implantation process by increasing an acute Th1 reaction, first for the addition to happen, followed by a Th2 modulation for the maternal fetal immunotolerance and blastocyst invasion to develop. But a critical approach of this literature, it questions the efficacy as even the RCTs, mainly in the recurrent implantation group, have reported comparable results to the non-RCTs. And there's only one meta-analysis on the recurrent implantation failure, which is very recent in the year 2020, and on 1,215 patients, which concluded significantly can increase. So the evidence cannot be really considered because it's not so powered and it's a weak evidence. Similarly, for GCSF, there are so many papers, and this also is thought to regulate the Th2 immunity to develop the maternal fetal immunotolerance. But the Cochrane review, which had included 15 RCTs, and they were most powered with 1,253 by our own scientist, Dr. Kamath, in 2020, showed a weak positive effect, but with caution due to the low quality of the studies, and there was a lot of uncertainty in the studies. Now, even in the RIF cases, though, Dr. Kamath had reported some benefit. So it is still not recommended in the general population, may be considered in the patients with RIF. Role of endometrial injury. Literature reviews until 2003, if you see, it was flooded with endometrial injury being the procedure to improve on the endometrial receptivity and pregnancy. Where are we today? Properly powered RCT on 1364 patients randomized to receive or not an endometrial injury prior to embryo transfer concludes that injury in a day-to-day practice does not alter the pregnancy outcomes in any way, may be considered in the special group of RIF. Intrauterine administration of HCG. So this actually stemmed from, because the thought is the HCG is the first molecule to participate in the crosstalk between the embryo and the maternal decidua, and it is expressed even at the 8 cells of the embryos following a specific pattern during the implantation and trophoblastic. So at the same time, a switch from the standard HCG to the hyperglycosylated HCG isoform is seen during the blastocyst hatching, involving in extravillous trophoblast proliferation and invasion. So from this thought process, from these studies is what the use of instillation of HCG just prior to embryo transfer stemmed. Where are we? We still need to watch and wait. As far as growth hormone is concerned, it's still under investigation. There is a rationality behind use of growth hormone because you have seen that they are expressed on the endometrium selectively during the window of implantation and also during early decidualization, which was what reported in 2004. So then it makes a sense that you could try giving them growth hormone, which can act directly or indirectly, can affect the VEGF and the integrin beta-3 expression, and it can improve the receptivity, especially in the thin endometrium also, as well as in the RIF group. But growth hormones, though it seems promising, it still lacks evidence and doesn't allow its use as a standard procedure, standard care. Coming to stem cell therapy for thin endometrium, Endometrium, we all know it undergoes a repair and a rebuild without any scarring. It is hypothesized that these endometrial cells, the stem cells, they play a crucial role in uterine homeostasis and in regeneration. And a loss of these cells can affect the receptivity. Efficacy, there are no RCTs nor comparative studies still available. There are serious concerns of the long-term effects and the risk of tumorigenesis. The health of the infants born after such treatment is still not available to us. Stem cell mobilization at this point of time is not recommended due to lack of rationale and due to lack of concrete RCTs, which could be powered to give us good evidence. Atosibon is a receptor inhibitor of oxytocin and vasopressin, and the rationality is that sometimes there is an increase in the uterine contractions, which can be detrimental for embryonic apposition. Shall I continue? Again, in this, we lack powered studies to conclude. As far as the intravenous lipid infusion, it is an immunomodulator, and most of the studies to date have used it only in an empirical fashion. Only one cohort study that is available on 94 patients, and it says that it can improve the endometrium, the live birth rate. So we still need to wait because of these side effects like hepatomegaly, jaundice, cholestasis, thrombocytopenia, and fat overload syndrome. Similarly, intravenous Ig immunoglobulin is immunomodulator, but RCTs are lacking. So until then, it is not recommended either by the ASHRAE or the ASRM. The metabolic and the endocrinological factors that you have to concentrate are thyroid, hyperprolactinemia, diabetes, especially in women with PCOS. Now, this is a recent concept. There's a lot of light thrown on progesterone. And there's a Cochrane meta-analysis which states that the increase in the live birth rate and the ongoing pregnancy rate with P4 versus placebo and no treatment for luteal phase, which shows that it can increase. Now, the recent matched cohort study showed a low mid-luteal progesterone levels could be more prevalent in women with a history of RIF, and hence it's worthwhile to test the progesterone because of this concept of the presence of progesterone resistance in many cases with decrease in the endometrial receptivity. But the local validation of the cutoff levels of P4 is recommended. Assessment of the late follicular or the mid-luteal P4 levels can be considered to improve with an intention of improving the ER. Now, for chronic endometritis, this is a concept emerging in the last 5 years, as we just saw. So there's a systemic review and meta-analysis, which includes 3 prospective and 2 retrospective studies, and compared patients with cured chronic endometritis versus persistent endometritis, and they found a significant increase in the live birth rate and ongoing in the cured group. So it makes a sense to understand if there is an underlying CE and address that. But then the assessment for this can be considered according to the guidelines, and the standardized diagnostic procedure for chronic endometritis in RIF is still needed, and if CE is diagnosed, treatment with antibiotics must be given. The concept is emerging, as I just said. The new approaches are quite promising, but there is lack of evidence at this point of time. Now, PCO is another condition, as I just some time back mentioned, that not only affects eggs and embryos, but it can have a dramatic effect on the various factors responsible for endometrial receptivity and implantation. So there are various pharmacological and non-pharmacological interventions that can improve endometrial receptivity, but there is limited clinical evidence supporting them. Most of the interventions, they lack validation in human studies, and no intervention is clinically recommended due to insufficient high-quality research, especially in patients with PCOS, be it the RPL group or the RI group. Role of oxidants, yes, you could try it. It's gaining popularity in the context that it can reduce the ROS and improve the endometrial receptivity. And in that sense, L-carnitine is quite widely studied in patients with recurrent implantation failures because it can improve the receptivity, shorten the time, reduce the estrogen valerate dose required, and improve the pregnancy rate. So if you look at what does Eshrey give us, these are all the methods that can be tried. This is in general routine ART patients. PRP, endometrial scratching, HCG, GCSF, seminal exposure to seminal plasma, supernatant culture media, stem cell steroids. None of them are recommended, and this is 2023 published in HR, Eshrey add-on working group. Nothing is actually recommended as a routine practice in routine IVF. Now, what about the RIF group? So again, this good practice recommendations on RIF is that, yes, review of the estradiol treatment, and if the endometrium remains to be thin, try to change the dose of the estrogen, the route of the estrogen, and you can review. It makes a sense. Genetic counseling, and wherever PGTA, maybe it is embryonic and not endometrial. Then optimize the lifestyle factors. Coming to what can be tried again as far as improving endometrial receptivity is intrauterine HCG according to the guidelines, antibiotics if there is an underlying chronic endometritis. Now, all the others like endometrial injury, GCSF, intralipids, immunoglobulin, PBMC, PRP, low molecular weight heparin, all these does not make any great sense, and they are not recommended by Eshrey. So all that I would like to say, whilst we are very, very distressed when we have poor endometrium, and especially in groups with underlying pathologies and in RIF, and we majority of the times adopt all these add-ons in other distress modality, only wish to say, be not the first by whom the new are tried, nor yet the last to lay the old aside. Thank you with that.
That was a very good, exhaustive, insightful session on the factors that are improving the endometrial receptivity. Thank you, madam. Shall we
Our
have
chairpersons are there, kya? Sorry to interrupt, Dr. Shilpa. Dr. Rekha was there.
Yeah, I'm there.
Rekha, please give your concluding remark.
Yeah,
We have
yeah.
to start the other one.
Yeah, I know, I understand. Okay, thank you, Dr. Durgadas and Dr. Shobha, Dr. Shilpa, for the opportunity. I, being the South Zone EC of Ksoga, is very much associated with this program. Dr. Nirmala, it was a good talk. You have covered all the points, many empirical, as you say. As far as our knowledge goes, the time-tested ones are for the RIF or the endometrial receptivity friendly treatment. The somehow to increase the pregnancy rate would be time tested are only probably heparin and aspirin, which we start as soon as the diagnosis of pregnancy is done, not even wait for the sac to appear, gestational sac to appear. Rest of all the treatment whichever you've enlisted have come and gone in their own waveform. So ultimately, it is a T2 pathway that we all bank on, and that part is very clear. The physiology that it is the encouraging the T2 pathway over the T1. That's immunomodulation, and thus the endometrial receptivity, endometrial embryo crosstalk improves, and that is what is ultimately, though the fetus we consider as a semi-allograft. And in spite of that, if we are not happy with our FET cycles, we go for the modified natural, or if your monitoring is very good, we go for the natural cycles, embryo transfer cycles. Thank you. Hello?
Yeah, can we have our next speaker, Dr. Rajlakshmi Valvekar? Her topic for today is role of endometrium in implantation.
Hi, it is actually Valavalkar. I'm not Valavalkar. Sorry. So yeah, thank you.
Welcome, Dr. Rajlakshmi Valavalkar.
Yes, thank you. May I be allowed to share my screen, please?
Yes, ma'am.
Dr.
You can
Shivani.
share.
Oh, sorry, Shivani.
Just a minute. I can't see my tabs. Sorry, I
Dr.
can't see the
Nirmala has
tabs
to
here.
stop sharing, first of all.
Yeah.
Is in the process, and then only you can open, Dr. Rajlakshmi.
Yes, I know. So the previous screen is already being shared. If they stop sharing, I can share my.
That's what I'm saying.
Yeah.
Yeah, now it is done.
Just 1 second. Yes, there we are. Okay, I'm going to go on to the slide mode. Hi, everyone. So, firstly, let me start by thanking Ksoga, patrons Dr. Hiremath and Dr. Nagraj, President Sir Dr. Durga Das, the learned conveners who've selected such a fantastic topic for today's CME, Dr. Anuradha, my dear, dear friend, Seema, my other dear friend who I think is busy somewhere else, and Dr. Shilpa, who's very kindly introduced me. And our chairpersons for today, Dr. Shobha Goody and Dr. Rekha. So, firstly, thanks a lot for giving me this opportunity for speaking on the endometrium and implantation. I very fondly like to call the endometrium the silent
Dr.
gatekeeper.
Rajlakshmi, sorry to interrupt. Can you
Sorry, I didn't hear you.
You have to
make it full
slide
screen? I
share
think.
now. I mean,
Make it full screen.
full screen. Yeah.
Bus.
Perfect. Perfect. You are mute, Raj Lakshmi. Please unmute yourself.
Yes,
Yeah.
I did. Sorry. Teething troubles, I think. So yeah, I fondly like to call the endometrium the silent gatekeeper because ART has improved by leaps and bounds over the last so many years. We now have PGTA and time lapse and everything, and yet our live birth rates are not increasing to the level at which we would want them to increase. And therefore, if you are already taking care of the embryo, one needs to take a look at the other partner in this dialogue, which is the endometrium. And the endometrium is not alone. It has got multiple aspects to it that govern whether our patient is going to get pregnant or not. There are hormonal aspects, there are cellular aspects, there are molecular aspects, the genetics, the immunity, the microbiome, and the pathologies that affect the endometrium. So that is what I'm going to concentrate in this talk. So as we said, the implantation is a dialogue, and the endometrium is what is going to determine our success. And therefore, we need to decode the receptivity, what makes it receptive and what makes it receptive. We need to examine our understanding of what receptivity is, and we need to look at in what future directions we need to go to improve our outcomes. So the more you read, the more you will know. The more that you learn, the more places you will go. And therefore, I thought we will start by studying a little bit about what we already know about it. So the endometrial changes. So what happens with the endometrial cycle? So initially in the menstrual phase, the top layer or the functional layer where all the action will happen gets shed. And therefore we have a new functional layer every month. And the spiral arteries are constricted at this minute because obviously we have to control the amount of blood that we lose. Then comes the proliferative phase where the estrogen becomes the king. It becomes the command giver. The glands are going to start elongating. The stroma is going to proliferate, and we see active mitosis at this stage because now the endometrium has to grow and become ready to accept the embryo.
You're not audible. It is not clear. It's breaking.
Dr. Raj, we can't hear you. We can see your screen.
Oh, sorry. I think I was logged out of here for a second. Can you still hear me?
Yes, we can
Yeah,
hear
sorry.
you.
So in between this, somewhere we have the receptive phase where the vessel velocity reaches its peak, the glandular secretions reach their peak, and the epithelial proliferation starts reducing. Now it starts going into a stable layer, and if you see here, it becomes most fluffy and the softest. So it's like a soft bed that we create for our baby to lie in. Similarly, the endometrium creates a soft bed for the embryo to lie in. So therefore, if we try and take a look at the endometrium from the point of view of implantation,
You're not audible, Dr. Raj Lakshmi.
Dr. Raj?
morphologic changes of stromal edema, glandular secretion that we've already seen, and the pinopores. So the pinopores are these special projections, bleb-like projections that come on the surface, and their main action is to absorb the secretion in the cavity so that the embryo doesn't keep freely floating around, and therefore a special mention to them. And despite all these things happening, we sometimes have chrono disruption where the embryo and the endometrial alignment goes away, and that's where we don't get an implantation. And therefore, we need to understand where the alignment lies and what causes the disruption. So this slide just talks about the implantation. I've touched up upon it. So the orientation of the embryo. So the inner cell mass will try and come in line nearer the endometrium. The pinpores will develop. Then you have opposition. So they will come opposite to each other, lie opposed to each other. Then there is an adhesion. So then they'll stick to each other. Okay, and then after that there is an invasion and burrowing, and then the embryo actually burrows underneath the epithelial layer. The epithelial layer reforms, and your implantation is complete. So that's the process in short. So for all this to happen, the first thing that we need to take a look at are our hormones. So what we need is we need our estrogen and our progesterone to be in optimal balance. We need the estrogen priming, and then we need the progesterone for differentiation and receptivity. Now let us take a look at natural cycle versus modified and HRT. What happens there? And these explain what happens there. So with HRT, even though we have scheduling, because it is an HRT cycle and there was no corpus luteum, the natural signals that would have otherwise come from the progesterone that was coming from the corpus luteum are gone. And therefore, natural cycles give us a better physiological milieu. I thought I'll add this here just because we keep ourselves aware about when we prepare our endometrium for our transfers. And at the same time, what we have is we have an endometrial transcriptome timing. So remember that even though the endometrium becomes nice and beautifully thick, if this transcriptome is out of sync with the thickness, we will get asynchrony. And that is what we see with the hormonal environment. So madam touched upon the progesterone being, the endometrium being non-responsive to progesterone. This typically causes a transcriptome timing imbalance. So when the hormones work, the cells will start infiltrating. And this slide is a single slide that very quickly shows us the differences that we see. So the natural killer cells and the macrophages are the two major cells that will peak at the time of implantation. Okay, and we will discuss about them in the next slide here. Now with these, we also get something called as molecular markers. So when cells comes, they will code into different molecules, and the molecules will go up. So the first molecule that we have to that is important for us is the leukemia inhibiting factor. Now this factor is what is going to initiate the implantation cascade. This is the first signal that goes out. At the same time, you have the homobox genes 10 and 11 come into play, and they start increasing the stromal receptivity. Now, we talked about the pinopores. Two things along with the pinopores come into action here. You have the integrin alpha V beta 3, which is an adhesion marker. So it causes the adhesion to happen, and this will peak. And at the same time, the MUC1, the anti-adhesion mucin, will get downregulated. So pinopores are taking away the water. Integrin is increasing adhesion. The mucin is getting downregulated, and therefore adhesion is going to happen. And the osteopontin at this minute is going to bridge the gap between the integrins and the extracellular matrix, and that is where your adhesion is completed and your infiltration will start. There are certain biomarkers that are being studied, like the glycodelin, the insulin-like growth factor BP1, and the IL-1 beta. This goes into the PhD level things, but I've mentioned them because we will start seeing papers on these very soon. Now the endometrial immune system also gets active at this minute. And the endometrium has got its own immune system and its own mind about what it's going to do. And three main things we have to think about when we talk about the endometrial immune system. The decidual natural killer cells. The decidual natural killer cells are going to promote remodeling and will secrete cytokines. And cytokines act as chemoreceptors for everything. Sorry, chemotractors for everything. The macrophages that come in are the M2 polarized variety, and they start tissue repair. Because when the endometrium goes up, when the trophoblast, when the embryo goes in and embeds, and the trophoblasts start coming out, a lot of tissue damage happens. So these macrophages do not eat up only the dead tissue, but do not harm the embryo, which is also growing. Okay, and they also bring in with them immunotolerance. So that is the speciality of the macrophages in the endometrium. And at this time, the Treg cells also come into action. Okay, so the T regulatory cells, and they are going to suppress the effector responses, and therefore the fetal tolerance develops. So any of these don't work properly, we get our miscarriages. So what we get here, in short, is we get a control of inflammation versus immune tolerance. We need a little inflammation for further proliferation of trophoblast, but we need immune tolerance so that the immune system does not go and kill the embryo that's coming in. And we need a crosstalk that needs to happen between the HLA-C and the maternal KIR genotypes. And this is important. And why is this important? This is important because the implantation success depends on it. And the later on, whether our patient is going to be developing preeclampsia is also dependent on this. Okay. Yeah. So if you never did this, you should do it now. These things are good and fun is good. And what are we talking about? We're talking about our microbiome. Microbiome is the new kid on the block. And it came in through because we know from swabbing and other testing that the endometrium is not sterile. Okay. So whenever we have a lactobacillus dominance in our microbiome, receptivity of the microbiome increases. And this happens because it keeps the pH low. They have an anti-inflammatory action and they bring your cytokines into balance. But at the same time, if you have dysbiosis, if you have things like Streptococci, Gardenia, Atopobium bacteria, all these going up, inflammation increases and that leads directly to implantation failure. So therefore, the microbiota are going to be modulating the mucosal immunity, improving the immune responses, and therefore the microbiota are something that we need to take a look at. Now, there are certain pathologies that the body or the uterus will go through, which are also going to be having an effect on the endometrial receptivity, whether it's going to accept our embryo or not. The thin endometrium, Asherman syndrome, chronic endometritis typically will have less vascularity. So whatever your estrogen and progesterone did with your blood vessels and your stroma, all that is negated, or all that doesn't happen at all. The fibrosis happens, and therefore you do not have proliferation of your spiral arterioles. And inflammation that is there locally is going to be having a direct effect. Progesterone resistance, I've touched upon this in a previous slide. Madam also talked about this. So anything that disrupts the progesterone signaling is going to hinder decidualization and therefore is going to have a direct negative effect on the immune modulation, and therefore implantation will fail. And endometrial aging. So we know that older women, even though everything is perfect, just don't have as many pregnancies as younger women are going to see. So implantation rates are much better in younger people than in older women. And that's purely because of altered gene expression. Because the old age genes, the senescence gene markers increase as you start aging. And therefore, the genetic fingerprint is disrupted and therefore we do not get implantations. But if that is happening, I've got a bat and I'm ready, you see. Now all my troubles are going to have trouble with me. And what did I do with this? I bought in the era. The era was bought in because people thought all these things are messing around with the implantation window. Let me pinpoint the implantation window, and therefore I will get an implantation. And the era was bought in to detect the transcriptomic signature of the receptive endometrium. And people thought this was going to be making the endometrial transfers more personalized. But that didn't really happen. Why? Because there is an intercycle variability that you see even when you do era in two patients if it is repeated. There is a cost factor. You can't keep doing it all the time. And it is not predictive for all people. It is predictive only in certain people. And therefore, now we are looking at things like tax sequencing, which is a high resolution transcript counting. So therefore, we actually count the number of sequences better, and therefore we have a better option. The uterine fluid based onomics have come in. Onomics are coming everywhere. And we have the Be Ready panel that Madam touched upon in her talk. So I'm not going to repeat that. So with all this, what has happened is that now that we've understood what goes on, we've tried to bring in emerging therapies. Okay, so like a flower can grow even on a cactus, we thought we will have some therapies coming up. So we got in stem cells, we got in PRPs, got in GCSFs, we got in our exosomes. And the aim of all these was to restore or enhance the receptivity. So the receptivity is gone, to try and bring it down to its baseline level, or if it is already there, to try and improve it. And how do we expect them to work? We expect them to work by either regenerating the endometrium, or by improving the blood supply and the angiogenesis, or by immune modulation. In these therapies, there is another new kid which is coming on the block now. And this is an organoid. So this is an artificial organ that can be created, which is the artificial endometrium. So what do we do here? We do 3D self-renewing cultures. So, you must have come across, reports where entire 3D printing of an external pinna is being done. Entire 3D printing of a nerve is being done, which is used to cure nerve trauma and things like that. We thought we could do something same with our endometrium. And therefore, 3D self-renewing cultures have become successful in our lab. And what do they do? These cultures as replicate my normal endometrium to do. I'm getting this from these. So instead of doing a TCRE, maybe we do a gentle scraping, and then we find out a way of getting these implants into the sorry, I think I got switched off again for a second. So we sort of implant this and hope that from the basalis layer, these organoid endometrium will take up and regenerate a completely new endometrium for us. And that's a new kid on the block, and I'm hoping to see this in action hopefully in 10 years' time from now. And because of the organoid that we have been able to develop, it has got multiple offshoots that go out. So if you take a look at its circle there, I will send this slide to you later on if you want. What all is it allowing me to do? It is allowing me to have a specific drug testing in a patient. So, when you don't, when the valeric doesn't work, you try and use the hemihydrate or something like that. It will allow me to test specific molecules in specific doses. It will allow me better hormonal response profiling in these patients. And I might get individualized implantation studies in these patients. So I can take a diseased endometrium from my patient, get an organoid, and run an era on the organoid. Therefore, it gives me a better information. And that is the future that we are hoping to see soon. Sometimes the questions are complicated and the answers are simple, but the answers for our endometrium are not simple because whatever research we are doing now, we have major gaps in them. Whatever we know as of now is currently predictive and not diagnostic. So, what does it mean? It means that I remove a sample and then I'm told whether it was receptive or not. It doesn't tell me whether the next cycle is going to be receptive or not. And therefore, the predictive biomarkers themselves remain elusive for us. They're not 100% predictive. Then there is a temporal dynamic of the endometrial function that we are unsure about, because I do not know in real time what happens with my markers. Because when I do my error testing or when I do any testing for the marker, I do it at one point. There is no way of testing. So hopefully uterine fluid onomics might answer this, but we don't know. And we do not have a global receptivity index. Nobody has worked on a global index that takes a look at your microbiome, your endometrium, immunology, your transcriptomics, your patient profiling that we talked about in the previous slide, your hormones, everything put together, giving me an index like a fertility index, a receptivity index, telling me whether my endometrium is going to be receptive or not. I'm sorry. So in conclusion, I would like to say that the that the implantation is not only about a good embryo. I also need a competent endometrium to give me a baby. There is a paradigm shift which is happening in the way that we look at our endometrium. We have gone from looking only at the structure. So day 21 biopsies are no longer being done. Day 21 progesterones alone are no longer being done. We are taking a look at multi-onomics and temporal analysis is what we are looking forward to. And our future of getting pregnancies completely lies in individualization and integration of services and therapies that we have. And yes, we will succeed. Yes, we will indeed. 98 and 3/4% it is guaranteed because nothing in medicine can be 100% guaranteed. And with that, thank you and Jai Hind.
That was a very good talk, Dr. Raj Lakshmi. You've given us a food for thought, a need for global receptivity index. That's a good thought. I will, next we will go ahead with our panel discussion.
Thank
Can
you
I
so
call
much.
upon?
Thank you for having me.
It was very good, Dr. Raj Lakshmi. Shall we have our moderators, Dr. Lavanya and Dr. Rashmi Patil, and our experts, Dr. Kundavi. I think Dr. Rajesh Kuradia left for the day. So, Dr. Lavanya Kiran, please, the floor is yours. Please take over.
Thank you. Thank you, Ksoga, for this wonderful opportunity. Thank you, Shilpa. Thank you, Durgesh sir. And coordinators of this program, Dr. Anu, Dr. Seema, wonderful job. I would request my co-moderator, Dr. Rashmi Patil, also to join me along. And we have wonderful...
Can I interrupt? Can I have CV
Oh,
of
yes.
Dr. Lavanya, please? Dr. Lavanya is lead consultant at Kaveri Hospital. She is an infertility specialist, laparoscopic surgeon, robotic surgeon, and she has so many feathers in her cap, including stem cell regeneration, cosmetic, everything she's doing, and a very good obstetrician gynecologist, and a very good friend of mine. She has lot of international papers to her the kitty, and she has gone internationally, and every 2 months she'll go and present some papers. So welcome, Dr. Lavanya.
Thank you. Thank you, Dr. Anuradha, for this wonderful opportunity.
Can
With
we have
me-
Dr. Rashmi's CV? Rashmi Patil's CV.
I can introduce Rashmi if it's that's, yeah. Okay. Okay, Shilpa. Dr. Shilpa, yes.
Yeah, Dr. Rashmi is current consultant obstetrician gynecologist, laparoscopic surgeon at Apollo Hospital, Banalghatta Road, a founder and COO of Raise Academy Private Limited, an online educational platform, chief mentor for training MRCOG and EFOG, EBCOG Global Online Course. EC member of BSOG 2023-24, joint treasurer elect BSOG, EC member BRCOG 2023 till date. Dr. Rashmi has got Mrs. Chandravati Devi Jagannath Singh Prize Poxy, Traveling Fellowship Poxy Pass Young Talent Promotion Committee and MTP Committee Award, Dr. L.M. Shaw Prize, Dr. Ashok Mehra Award, Dr. Pramila Bhatia Young Scientist Award, Best Resident Award, MWS, Traveling, and Dr. B.R. Desai Founder EC Member Award, Best Video Presentation in Endovision 2018. She's got a lot of national and international journals, 3 chapters in her books. Over
Doctor,
to you, doctor.
could you please display Dr. Kundavi Shankar? She's Tapisar Vice President.
Welcome,
Dr.
Dr.
Shilpa.
Dr. Rajesh Kuradia is MD HOD of Mira IVF Center, Mira Bhayandar, and Mumbai, founder of Verdict Group, which is a group of more than 1,200 IVF specialists for academic discussions. Dr. Koradia is very passionate about teaching. Can we have Dr. Kundavi's CV? Dr. K.M. Kundavi Shankar, she has 30 years of experience. She's the senior IVF consultant at Triple M Hospital, Chennai. She specializes in IVF, IUI, MTP, hysteroscopy, laparoscopy, and advanced fertility treatment. She holds an MBBS, Kilpock Medical College, DGO from Sri Ramachandra University, and DNB from NAMS. Dr. Kundavi is a respected member of various national and regional gynecology and fertility societies. Welcome, Dr. Kundavi. Can we start our
Dr.
panel
Lavanya,
discussion?
you can start your panelists and you can invite your panelists yourself.
Sure. Thank you. Thank you. Thank you so much. Thank you, all of you. I invite all my panelists, I can't see my co-moderator, Dr. Rashmi, you're there?
Yes, ma'am, I'm there.
Okay, yeah. Welcome, Dr. Rashmi. So me and Dr. Rashmi will be the moderators of today's panel, where we've already heard so much about endometrium and preparing the endometrium, of why endometrium is important. To have this wonderful discussion, I think we have stalwarts of VRT, I would say. And these are my panelists. We have Dr. Nagesh from Tumkur. All my panelists are leading fertility specialists. And Dr. Hema Mati, Dr. Satvik, Dr. Sujay, Dr. Savita Mahesh, Dr. Geeta Bharat, Dr. Vidya Mahadev, Dr. Asha Rani, Dr. Chandana, Dr. Santosh, Dr. Shaviz. So we have people across Karnataka from different districts, and this is what Ksoga is about, involving all the zones. All the IVF specialists are here, and we have the panel expert, Dr. Kundavi, who's from Tamil Nadu. Welcome to each one of you. And as we begin this discussion, I think we all know and we've understood now that the endometrium is very important, and this is where the crosstalk happens, that is between the embryo and the endometrium. Endometrium is the soil, which is really, really important. And as we understand, there is so much of physiology, and Dr. Nirmala, Dr. Raj put it across so beautifully well of why it is important. We just want to know from the panelists takeaway points. There's no pointing out, we want this person, because all of you are experts. You can just come up and say just a gist of what do you think the concept behind this is, the endometrium and the embryo crosstalk. What is the important point? Why do we have to prepare the endometrium? Any of you can pick up the questions, no pointing out.
Ma'am, can I come in? Dr. Shaviz from
Yes, Shaviz. We start from the youngest.
Good
and the
evening,
beautiful
everyone.
one.
I would also like to take this opportunity to congratulate Lavanya ma'am and Anuradha ma'am. They both are here, along with Santosh ma'am, for an excellent conference. We had a great time. We're looking forward for the next one.
Thank you.
So, like we've already heard from the stalwarts that the endometrium is the holy grail for an implantation of the embryo, which is hopefully a euploid embryo. But then, based on the estrogen, the estrogen preparation that we have of the endometrium, first there should be an adequate exposure to estrogen, which helps build up the endometrial thickness, and along with the basic androgen, the angiogenesis. Based on that, we have after that we'll have the effect of progesterone, which brings about the destabilization, which is extremely important, and also exposure to progesterone will open the window of implantation, and that will help in the implantation to occur and then further progress. Along with that, there should also be the immunological changes that occur and that help in implantation and then further progression of the pregnancy.
Thank you. Thank you, Shaviz. That's really important. I think all really put forward the importance of estrogen. And I think even in the FET cycles, the age of the embryo and the synchrony of the progesterone exposure is very, very important as well. And we'll talk about, I think we heard quite enough about receptivity of the uterus. Dr. Rashmi?
Yes, ma'am. The next question I would like to hear from the panel is that what are the parameters that are important whenever you're thinking about endometrial preparation? What thoughts do you have about the scan or the blood flow? So what parameters are you really looking into?
Should I answer this or?
Oh yeah. Dr. Santosh, you can go ahead. Any of you can start picking up because all of you are so very well qualified. We don't want to pick and choose.
No,
so you
but we
can
are so
choose your
many.
favorite. Oh yes, you can pick up. First come first.
No,
It's like
another thing.
ringing the bell.
Okay, so
Whoever picks
basically
up
I'm
and-
talking. Okay, so I have rang the bell. So basically when we are looking for the endometrial preparation, so parameters are the endometrium should be well prepared. So we will look for the thickness of the endometrium. We will look for the texture. There has to be a triple line endometrium. Then next come about the blood flow of the endometrium. So these are the three most important, and obviously absence of other pathology like polyp should not be there, free fluid should not be there. These are the most common important points in a general IVF frozen embryo transfer cycles.
Yeah, I think all the points are really beautifully brought forward for. When Dr. Santosh mentions that we need to have the right endometrial thickness, we don't want to be having any pathology like the polyp because it hinders the implantation. We want to have the blood flow reaching up to zone 3, zone 4, and this is what we look at the Doppler. I want my panelists to answer. Do you see that there's a difference in the natural cycle or an hormone HRT cycle while we are preparing for an endometrium? Is there any changes you want to bring into the protocol while you prepare the endometrium?
There is definitely a difference in natural and artificial cycle, because in natural cycle there is a corpus luteum and we cannot predict how much progesterone it is secreting. Also in natural cycle there are other things secreted by the corpus luteum. In artificial cycle we are only providing progesterone, and we cannot individualize. Only we are monitoring endometrium and deciding the dose. Otherwise there are no other factors involved in an artificial cycle.
Please, Dr. Santosh, you can bring in your points.
Yeah, so basically, as the name suggests, natural cycle means we are allowing that lady to naturally grow her egg, and the follicle itself is releasing the estrogen, and the natural estrogen is making the endometrium. The only difficult part in the natural cycle, because it seems very easy, but monitoring of patient is difficult. You have to really track on when the follicle is ready and when it is ovulating. So it is totally based on the natural cycle, and post ovulation, as the number of days of the embryo, you can decide your transfer. Whereas the artificial cycle is planned mimicking the natural cycle. In general, as a clinician, it gives us advantage. Like you give a estrogen first. When your lining is ready, you can program the progesterone exposure and you can plan the transfer. So artificial cycles are more convenient, but as we know, the natural cycle corpus luteum is not about estrogen and progesterone. it secretes many more substances. That's why if we are able to do natural cycles, the pregnancy rates and first trimester bleedings and all are lesser in the natural cycle.
So as we understand that, natural cycle is
more than pregnancy rate, placental insufficiency and other problems will be less within a natural or MNC cycle than artificial cycle.
Totally agreed. And I think even the miscarriages in the first trimester is more, much lesser in the natural cycles. And I think even the results are also much better in the natural cycle. Yes, I totally understand what Dr. Santosh is saying, because it can be more personalized, convenient for the obstetrician, for the patients. The monitoring is much lesser. I would like to ask my expert, Dr. Kundavi, what is your what is the kind of transfer that you would prefer, natural cycle or an HRT cycle? Or modified natural cycle? I think that's our next question. But before that, Dr. Kundavi, do you want to put in some points?
Lavanya, I agree with all the panelists. Patients got irregular cycles or patient with previous history of thin endometrium or any fluid in the cavity or something. I think the natural cycle would be a better option. But patient who's got an irregular cycles, probably the artificial cycle would be beneficial. But patients, I think as the people have said, the corpus luteum is very, very important so that you can avoid the pregnancy-induced hypertension and small for gestational age as well, if you have a corpus luteum in an FET cycle.
And I think, more people moving towards the natural cycles these days, and more of modified than the HRT cycles. I think, in my practice, I'm seeing quite a lot of, I don't know why, this echogenic foci. I think I'm seeing more in HRT cycles, and somehow I've started moving towards modified and natural cycles more than the HRT cycles. Is anybody also having similar issues while you're doing an HRT cycle?
Yes, I very often, like these HRT cycles, you get free fluid, and as you said, echogenic foci. Sometimes triple line do not come, and moment you allow them on natural cycle, nice, beautiful triple line endometrium comes, and even RIF patients also sometimes get benefited by the natural cycle. So,
Dr. Nagish, what do you do when you see an echogenic foci in the, everything looked very beautiful on the day 3 or day 4 of your progesterone. You have a day 5 embryo sitting there, and you've done your Doppler zone 3, very good endometrium, clear triple line, and then finally you call her one day before your transfer and you do a scan and you're seeing a thick echogenic foci. How do you go ahead if it's just one echogenic foci? Just one, or if there's a thick lining of an echogenic foci, what do you do? Do you cancel or do you go ahead? Anybody else can pick up the question? Nobody answers.
First of all, actually, all my patients are previously monitored even before the treatment cycle. So if anything is seen, I would like to tackle at that time. You mean like echogenic foci means polyp. So that is better delineated during the proliferative phase. If it is small and it's sitting lower down, we can actually just leave it. If it is more than 0.5 to 1 centimeter upper cavity or mid cavity, we may have to tackle that. And it's an ultrasound, it is better delineated during the proliferative phase.
Dr. Santosh, do you want to add a point when you see it's not actually a polyp, but you're just seeing that echogenic foci sitting there?
See, echogenic foci, we have to define, as you said correctly, if it is very small and isolated echogenic foci and other parameters are normal, we can leave it. If you have seen it repeatedly, then obviously hysteroscopy has to be done. If it is a larger foci or multiple foci, definitely there has to be something. And we should not forget about the pre-decidualization of endometrium. So that also sometimes creates echogenic foci. So when you do the scan, you know whether it is a polyp or it is a simple echogenic foci. That I think while doing size and location and multiple, all these things will add on.
And these echogenic things most often seen when the uterus is mid-posed or when the uterus is retroverted. Sometimes when you give when you do a probe maneuvering, sometimes you can make the uterus antiverted. When it was retroverted, you can see a nice triple line in such cases also.
Yeah,
I think
position of uterus also matters during scan.
Yeah, and
also,
I think
also, ma'am, getting a good 3D ultrasound you can really differentiate whether it's a polyp or just a thickened endometrium that is there. If it is just an echogenic foci, I think we are good to go ahead with the transfer.
Yes, yes.
And other thing is like uh, 2D 2D grayscale is good enough to delineate the
Delineate a
echogenic
polyp.
foci,
Yes.
and 3D sometimes it misguides. We may have to adjust the gain. Yeah.
I think the previous
Smaller ones.
cycle, if you know that the cavity is normal. Yes, Dr. Nagesh, go ahead.
Yeah. No, on 3D, small subtle ones, we miss it actually. They are better delineated during the
2D
proliferative phase on grayscale.
The
we
previous
are
cycle
confident
before we go, Lavanya, before we go ahead in an FET cycle, if the previous cycle shows echogenic foci or a polypodal endometrium, I think those are the patients where you can definitely take them for a natural cycle when compared with an HRT cycle, because adding estrogen could also bring in this echogenic foci, especially in an adenomyotic uterus where you could see all this.
I totally agree with Dr. Kundavi, and I've changed quite a lot of my patients. Started with HRT when we see this echogenic foci, of course, monitored, and the previous lining has been good. Especially when the HRT cycles, because of this exposure of this estrogen, we are seeing a lot of this echogenic foci. When we do a natural cycle, the lining is good, the pregnancy success rates are much better. And I agree with Dr. Kundavi. I think that natural cycles would be much better. Over to Dr. Rashmi.
Yes, so my question to the other panelist, what are the different types of ART cycles that you plan?
ART cycles means for embryo transfer.
Yes, yes, for an embryo transfer, we'll talk only about the endometrial receptivity.
We can do natural cycle IVF, modified natural, stimulated, or artificial cycle or HRT cycle.
Dr. Sujay, do you want to start with, how do you want to do a natural cycle?
The whole procedure, ma'am?
Yes.
Yes.
This is for the benefit for all our people who've logged in. We have a lot of delegates from the OG societies of different districts as well. So.
I think that the name itself tells that it's a natural cycle, ma'am. Initially on the day 2, probably we're looking at, we do a scan on the day 2 and look for any cysts or anything. I hope if everything is normal, we can start off with probably monitoring the cycle, and around 8 to 10 days, we call her back. And once you see for a dominant follicle which is forming, I think which we can ask the patient to come back after a few days, like based on the size of the follicle. And probably around 12th day or 13th day, you can either see for signs of rupture or probably monitor them with an LH or an E2. And based on those signs, you can take a call of whether you can go ahead with but the problem with natural cycle is it needs a lot of monitoring, and the scheduling of the cycles becomes a little difficult. So routinely, I think that's the problem why most of them are not using natural cycles.
Anybody of our panelists doing natural cycles here?
Yes, ma'am. I do natural cycle.
Shaviz, then I think will be the best person of how you want to monitor.
It does become a little inconvenient for us, and sometimes even for our embryologists, they'll be cursing me. But then because see, the thing, to summarize it for people to be very clear about it, we need an endometrium which is thick enough, and then we need progesterone exposure so that the endometrium becomes receptive for the embryo. So it's as simple as that. So you either build the endometrium with tablets like estrogen, which can come in various preparations, or you depend upon the natural estrogen which comes from the dominant follicle as the follicle grows. Now, the follicle can grow naturally, how it grows in every cycle for a regularly ovulating woman. Or if you feel that she's not regularly ovulating, you can induce ovulation with the help of ovulation induction medications like say letrozole, or we don't prefer to use clomiphene because it has anti-estrogenic effects. So once the follicle is grown, say in a natural cycle, along with that, with the estrogen secreted by the follicle, the endometrium grows. So usually, once it is grown, there will be an LH surge, and that usually happens after, say, when the follicle reaches about 19 to 20 millimeter. But sometimes in some people, the LH surge can happen a little early. So it's always better to monitor the follicle after it reaches practically, say, about 16 to 17 millimeters. Sometimes in elder women, the LH surge can be earlier also. So once it is about 40 millimeter, you can start monitoring the LH and progesterones. And depending on the size, like Dr. Sujay said, depending on the size of the follicle, you can call her either once in 2 to 3 days or even alternate days, so that you don't miss the LH surge and the progesterone rise. We have certain protocols as to when, after the LH surge, we have to place the embryo, transfer the embryo into the endometrium. So depending on the LH surge day or the progesterone rise day, we will we'll calculate the days, and we'll be transferring the embryo into the endometrium. We also like to supplement with progesterone, although it is a little controversial. Some people say yes, some people say no, but we usually like to supplement with progesterone once the LH surge has occurred.
Anybody agrees here that when we say natural cycle, Dr. Vidya, Dr. Kudavi, when we say natural cycle, do you want to keep it totally natural and then otherwise call it as a modified natural cycle?
Actually, natural cycle is totally natural. When we do monitoring with LS surge and ultrasound only, no drugs are added. Maybe progesterone support some people add, but for inconvenience, it is changed to modified natural, where no stimulation is given. Naturally, only estrogen is produced, and we time the cycle by the SCG. Or if we get good endometrium with small follicle also, people start directly with progesterone. So there are two types of modified natural cycles.
I think natural cycle is natural
cycle
cycle.
is
You don't
totally
have to
natural.
give the HCG. But in a modified, I think people give HCG trigger, and then they don't even give the progesterone support because you're giving an HCG as well in a modified natural. But as the other speaker said, it is little inconvenient because you may have to come for your transfers on a Sunday. You have to bring the team on a Sunday if you have to go through these. Whereas it is an artificial, it's flexible for the consultant as well as an embryologist.
Yeah, I think it's very important to note when we say natural cycle, it is to be totally natural while you're monitoring your LH, you're calling her more frequently, weight, of course, despite all these inconvenience, there is no progesterone needed in a natural cycle. Only if you're talking about stimulated cycles, then we talk about trigger, and then, of course, progesterone is an optional thing, but then trigger and progesterone comes only if it's a stimulated, it's a modified natural cycle. Dr.
One more
Chandran, do
point
you
I
want
want to add.
Can I
Yeah.
add, ma'am?
Yes, Dr. Asha, please.
Yes, thanks for the opportunity, ma'am. In spite of meticulous monitoring in natural cycles, there might be spontaneous ovulation can occur at any time. So there might be early progesterone rise. We will not be knowing where exactly the progesterone has raised. So there might be alter of window of implantation. So that is the main drawback in natural cycles.
Totally agree. This is why I think frequent monitoring is most
But in natural cycle, the window is very big. It is almost 4 to 5 days. So little up down is okay. For me, I did one natural cycle only, because the patient came at day 10 directly instead of coming day 2. So she was young. I was having 4 straws of blastocyst. So I monitored her with LH, but pricking her again and again was only the problem for me. I got pregnancy with her, but that day I found it is very good, because she never came with first trimester bleeding. She delivered nothing. She was like a natural pregnancy without any drugs,
And
only iron calcium.
one more advantage, there are a lot of patients with medical disorders. Like if we expose them to synthetic estrogen, there could be thrombogenic events and many medical disorders. So natural cycle frozen embryo transfer is a good idea for them.
Yeah.
Modified natural cycle.
Modified natural cycle can be used for them for medical disorder, because it's easy. Pricking the
Easy
patient
and less
4 times,
monitoring.
it is very difficult.
Less monitoring, patients' visit to the hospital is much less. I totally agree.
And we can have a controlled ovulation.
Yes.
I think Lavanya would agree with me. Patients with previous history of hyperplasias and other things where the letrozole FET cycle modified would be a better option to these people.
Dr. Chandana, do you want to talk to us about the stimulated cycles?
Thank you, ma'am, for the opportunity. Stimulated cycle FET is when we give the patient either letrozole or tamoxifen. So these are for patients who do not ovulate. So these are generally for people who have PCOS, wherein we want to stimulate them, want them to have a natural corpus luteum. So we give them letrozole or we give them tamoxifen to build their lining. So we call them on day 8. We look at the size of the follicle and we do tracking of the size of the follicle along with the LH. And then we give them when the dominant follicle or even with the low dose gonadotropin. So this is a mild stimulation. So we also can give them low dose gonadotropin and stimulate them. And based on what stimulating agent we have used, so we trigger them when the lead follicle reaches the size of 18 millimeter or 20 to 22 millimeters in the case of oral ovulogen. And following that, so if we trigger them with a HCG, so we plan the transfer on HCG plus 7. So that's how, so from the day of the trigger, so the 7th day is when we do the transfer. So this is the modified, stimulated cycle HRT that can be done. Now, regarding the luteal phase support, there is a little controversy regarding whether LPS should be added to a true natural cycle or a modified natural cycle or stimulated cycle, with few reports saying that the HCG is good enough to support the corpus luteum. But few reports have shown that adding 800 milligrams of vaginal estrogen or 180 milligrams of the vaginal gel, progesterone gel, does improve the clinical pregnancy rate and the live birth rate.
I think recently Sujay got in a beautiful, Ksoga, what was that newsletter? When was the best? Yes, yeah, flash. So where when is the best time for trigger? I think wonderful job, Dr. Sujay. And Satvik, do you want to talk about the HRT cycle, especially when we're talking about fresh and frozen embryo transfers and all? HRT cycle, how would you want to go about, Dr. Satvik?
Yes, ma'am. Of course, HRT cycles are reserved for a few specific women who are either poor ovarian reserve or who don't really ovulate on their own. In these kind of patients, HRT cycles do really help. Usually, we start with estradiol, a little higher dose, 2 mg QID or just TID dose also is enough. And along with this, you can also give a down regulation in these patients, either by giving Lupride injections or the previous month you can give a long-acting Lupride depot injection also in these months. So you down regulate, then from day 2 of the cycle, you start with the estradiol tablets and keep following her up on scans, day 9 scan, day 10, based on the endometrial thickness. So one here we look for the thickness of more than 7 mm, good vascularity, triple line, good thickness of the endometrium. Then you can time your embryo transfer accordingly after starting the progesterone. So once we are satisfied with the endometrial thickness, we start with the progesterone supplementation. Then based on either day 3 or day 5 of the embryo, you start accordingly the day 3 days of progesterone or 5 days of progesterone.
So what kind of progesterone would my panelist prefer?
Mostly micronized vaginal
progesterone.
Yeah.
All of you.
Yeah.
So any difference of opinion in any of my panelists?
I think in an FET cycle, the injectable progesterones probably score.
For
People talk about
endometriosis
vaginal.
and adenomyosis, for endometriosis, adenomyosis patients, I prefer intramuscular.
The Cochrane, of course, says vaginal, IM, everything is the same, but since the efficacy is more better, bioavailability is much better. And I think the discomfort of an IM, definitely the vaginal is better. But yes, of course, while we're talking about FET cycle, especially in patients with adenomyosis, endometriosis, I think we do accept the IM, but then we'll have to consider the discomfort with our patients. Dr. Rashmi, you can go ahead with the cases, please.
Yes, ma'am. So one more thing which I wanted to ask my panelist is, how about the triggers? So do you prefer a single trigger or the dual trigger?
For FET cycle, only SCG trigger. Why trigger? For
Why
MNC
dual
cycle.
trigger?
Yes,
Why dual
yes,
trigger?
Doesn't make sense.
No, it doesn't make sense.
Always single trigger if for an FET.
Okay, and speaking about the transfer of embryos, have you ever considered a fresh, or is it like a freeze-all protocol that everybody follows?
If progesterone is less on trigger
No,
day,
it is not all freeze all, but
Not-
yeah, we
not
end up in
freeze all.
doing a large number of cycle as frozen
Yeah,
embryo transfer.
yes, yes.
I think yes, it's definitely. I think at one phase, most of us had gone into freeze-all cycles, but then we understand that the results of fresh embryo transfer, assuming that everything's going very well, the endometrium lining is good, and luckily we have nothing much, and we should be going for a fresh transfer. And yeah, of course, mild hyperstimulation, the endometrium lining is not good, then only going for FET. There is no need of all freeze-all. Yes, Dr. Rashmi, please continue with the cases.
Going ahead with the first case, a 29-year-old with the HSG suggestive of the bilateral tubal blockage. She is planned for the IVF cycle. Remaining investigations were found to be normal. So how do you like to proceed, and what endometrial preparation protocols would you suggest for this patient?
First,
So
I would
you're
like to
talking
know,
about fresh.
yeah. First, I would like to know why is there hydrosulfings? Is there another pathology in the tube? Then only I will go ahead. If I can see the hydrosulfings on ultrasound, then only I
So
will.
would you like to go ahead with the clipping or self-injectomy?
Yes, yes. If it is there, definitely.
Okay,
so many
how
times
many
on
of the
HSG, so many times on
Yes, sir.
HSG,
Yeah.
it will be a fast tubal block. So because of the spasm itself, so we may not see. Yeah.
It is only distal tubal block creates hydrosulfings.
Yes.
It could be a proximal
tubal block. No problem.
Tubal block, because information is only about tubal block. So if there is only tubal block and endometrial cavity is normal and there are no hydrosulfings visible, so it should be as any other frozen embryo.
Young patient, you can do MNC cycle, definitely.
Yeah.
Yes, ma'am. So in case of any preparation that is required for a controlled ovarian stimulation, so how would you like to prepare, and what are the protocols that you would like to bring into in such patients?
That is same as stimulated cycle. No?
I think we've discussed, we've discussed this in brief.
Latrozole, mainly latrozole, very less patients with mild dose of gonadotropins.
So I would like to ask the panelists that how many of you prefer clomiphene and how many would prefer letrozole?
Letrozole only.
Letrozole,
Clomiphene is already
letrozole.
having endometrial problems, no? So I to use letrozole.
When do you call if you want to give a gonadotropin, and when would you call
Clomiphene
the
nobody
patient once you
uses for an
started?
embryo transfer cycles. Yeah.
No.
Tamoxifen can be used.
Yeah.
If you are finding repeatedly thin endometrium, tamoxifen can be used. I have never used, but it can be used.
No, ma'am, I have used for a lot of my patients endometrium. It helps marginally.
For unexplained infertility, if you want multifollicular growth for good endometrium, clomiphene also can be used.
We have used tamoxifen 20 milligram BD, patients who've got a thin endometrium for 5 days, and it works.
Yes.
Totally.
But it should be stopped, I think 5 days before the trigger, because the effect goes on.
Anyway, we give it for 5 days.
It's given only for 5 days.
5 days.
So, Dr. Chandana, if you want to add a gonadotropin, when would you call them? How would you monitor when you've done a mild stimulation protocol?
So mild stimulation protocol, suppose I'm giving them on a continuous dose gonadotropin, ma'am, like a 37.5 international units daily. So for 5 days or 6 days, I call them on the 7th day to see the size of the follicle. If it is 14 millimeters, then I continue it till the size of 16 to 18 millimeters. And that's when I plan the trigger for them, HCG trigger, and plan the transfer on HCG plus 7.
Okay, perfect. And now, yeah, sorry, anybody else had any other opinion?
My gonadotropin stimulation is done in resistant PCOS only, or other cases also you do?
Only for resistant PCO who do not
And thin
respond to
endometrial
letrozole,
patients.
ma'am.
Yes.
Letrozole.
Now, if in a PCO patient, you've stimulated, you've got beautiful 13, 14 follicles, and because in the PCO, you know the endometrium is you go for a freeze-all. Now, for this PCO patient, when she's coming back, you want to plan your FET cycles. What would the protocols look like? Dr. Satvik, Dr. Sujay?
In PCO patients, ma'am, preferably we prefer to go ahead with the HRT FET. So because they are on their own natural cycle, they won't ovulate properly, and even if with the stimulated cycle, the oocyte follicle and the endometrium is always out of sync. So in
Yes.
such patients, HRT cycles are always better.
Down-regulated one.
Down-regulated one.
Down-regulated, yes.
So how would you down-regulate, and how would you give the HRT?
Lupride injection. Lupride injection, either we give half cc daily from day 2 onwards, or if you have seen her in the previous cycle, then you can give a depot Lupride injection the prior month. That is 3.75 international units. That will be the down regulation. Then from day 2 onwards, you start with the estradiol supplements.
No,
Do you want
there is no need of for day 2 onwards. If you give Luprat Depot on day 21 for endometriosis, severe PCO, we can call the patient after on day 14 or 15 when it is completely down regulated and start estrogen. Sorry. No need to calculate her menstrual day, second day or third day. She should be completely down regulated.
And the other one is like you can give a 10 to 12 days of oral contraceptive pills, and in the last 4 to 5 days you can give a depot injection, and when they get their periods, they can come on second or third day of the cycle and do a scan if they're not thin and there is no cyst, and mostly they will be down regulated. No, we don't need to do any hormones or anything. A scan should be sufficient. From day 2, 3 we can start estrogens. So in a step ladder approach fashion. So that's the way I'm doing it.
Yeah. Anybody using only progesterone only pill?
Yes. I don't use OC pills. I never use for OC pills for any IVF cycles. I'd see the endometrium. If it is 7 mm also, I will start with progesterone and give withdrawal and give the Luprat depot if needed. Depot is needed. Otherwise, for PCO also, if you start estrogen from day 1, 24 hours within menstruation, they will get down regulated with our estrogen dose. 6 milligram estrogen.
So do you start off with 6 milligrams at the beginning?
No,
or,
for PCO patient. For
PCO.
I do modified natural cycles only. For severe PCO patient where I don't get any response to latrose, I don't add gonadotropins. Instead of giving injection, I start with estrogen 6 milligram.
Dr. Shaviz, now we have a patient whose TB PCR was positive, and every time she ends up having very scanty flow, and that only on withdrawal she gets a bleeding. Now, what kind of a protocol would you want? Now we have beautiful day 5 embryos sitting there. How would you want to go ahead?
Ma'am, for her, I think the best thing would be to go for, I think HRT would be good for her because we can start her on a little higher dose and, then monitor and see whether that, probably 8 mg or a little higher than that and see if that is working for her. And call her for a repeat scan.
What if your HRT doesn't work and the endometrium ends up remaining thin?
So then
persistently thin.
So then we have.
First of all, we would like
You
to
have treated
know.
her for
The
ATT?
treatment we wanted to know.
Yeah.
Whether it's
But
treated or not.
patient has been treated in the past for a year, ATT, and the last dose was almost 6 months back.
So
For such
in
a
spite
patient who
of
is already diagnosed tuberculosis, I would like to do
in spite
hysteroscopy.
of
What
all
is the
kind of
endoscopic
therapies
condition
in
for her?
sorry.
If there are already chronic endometriosis adhesions inside, I would like to treat that, treat the dysbiosis of the endometrium. Then only I will go ahead with estrogen. And if estrogen she is not responding, you may take longer days or more dose also. You can try. She is 26 years old. We can try with latrose or gonadotropins also. But failures will be there. You have to wait till you get endometrium.
We can consider doing alternative therapies as well. If in spite of all kind of therapies, if she's forming thin endometrium, then we can use some advanced treatment like
regenerative.
So yes, hysteroscopy was done for this patient and there were additions. So the additions were released. How many of you, I mean, yeah, we did hear for the previous speakers, and how many of them would think of additional modalities of treatment for this patient while you're doing a hysteroscopy, you've done the idocytolysis. Anything you want to do to prevent this and to make sure that the lining is much better?
Additional diarrhea sometimes, and
PRP.
also PRP injections,
PRP.
hysteroscopy PRP injections.
Endometrial PRP will work for these patients.
If the glands are lost, actually, nothing works.
Can I answer one question? See, if a patient, yes, she has tuberculosis and she's not responding to oral estrogen, you can try transdermal, try another route. Maybe that works. Many a times it may work. Transdermal estradiol gel comes, so that you can try. Yeah.
So
And
yeah,
also
but
vaginal
everything was.
estrogen also we can. I think it will be helpful for few patients. Vaginal route of the estrogen.
But majority of the patients, especially very thin endometrium, especially like TB PCR, and our next question is also similar cycle where there was 2 surgical terminations of pregnancy. All these kind of patients are over enthusiastic DNCs leading into additions. I think it's very difficult, to get a good endometrium despite of different forms of estrogen being used. And I totally agree with Dr. Vidya and Dr. Santosh that while you do a hysteroscopy, of course I'm more inclined to PRP, stem cell and all, but we've seen wonderful results while we do stem cell and PRP, and really good endometrium gets built up in these patients. And while we do this, the additions are also much lesser in these kind of patients. And we are due for publication for 2 international journals where we have done stem cell PRP, and we've shifted now to stem cell, where beautiful results. And with India, I think tuberculosis is quite common, and especially terminations, DNCs. These are all something very, very rampantly seen. And like Dr. Nagesh mentioned, while we're doing our stimulation protocols, doing the screening scans, we can see those bands, especially if you're doing a 3D, and even stringently 2D is done, we can definitely see how you're seeing a free fluid in the endometrium. All these things can be seen. Dr. Nagesh, do you want to share any of the stories that you've treated for thin endometrium because of tuberculosis, or to DNCs in the past and additions, and you've done adisolysis?
Yes,
Any of you for that matter, you can
yeah,
share your
I have had a few
experience.
cases with respect to DNC. So it was a mid-trimester MTP where the bone was left inside, and the NHSC tubes were also blocked. And initially we did histoscopy and laparoscopy, and we removed the osseous bone, and the endometrium was also bizarre actually. And next follow-up scans, and again we did a relook histoscopy. Then the flimsy additions were released, and male factor was normal, she conceived naturally and delivered. And of course, on severely damaged endometrium, that is endometrial glands, on histoscopy, if they are sparse, is sometimes we get good endometrium with the PRP and other additive modalities. And if it is bald, so you may not really get the endometrium whatever you do.
But for such a patient, if you will never get endometrium 8 millimeter, because I was monitoring to many patients like this only till 8 millimeter, but afterwards I shifted that I should get good echo texture and good blood flow. So in that way I transfer, and I got positive result with 6 millimeters also.
Yeah, recently I had the similar case. Now it is now she is 7 weeks, and she had a dysmorphic uterus where I did in bilateral lateral metaplasty and also
These patients
subsequent resection.
thickness will
And
not be considered.
yeah, she had a very good, beautiful triple line endometrium, but it was only 6 centimeter, but with abundant blood flow. By discussing with them and with transfer, and she's considered, and it's ongoing pregnancy at around 7 weeks now.
Yeah, if they have a good basal endometrium, all these, if they have a good basal endometrium, all these therapies will work of PRP and stem cell.
I think patients who got a thin endometrium, like 6 mm, good triple line, as Dr. Nagesh said, I think it's fair enough to go ahead and do the transfers rather than waiting for
Totally
7 and 8.
And in the same case, actually, previously monitored cycles were also around 6 mm, 6.2 like that. Then I discussed the same with them and I transferred. But I took a chance to transfer. That's it.
And these patients, when we are stimulating, we are getting the estrogen almost more than 2000. That time also they are getting only 6 millimeters, means nothing will work for them.
It means there is end organ problem.
That time we should note that this endometrium is this much only. So we cannot give more than that dose.
Now, if you have a good embryo, I think with 6 mm triple line, I'm sure you can.
You should have applied good morphologically, at least good embryo.
Yeah, but I think the latest ISAR paper also have said that, less than 6 mm, you can even achieve 30%. So I think they are in the group of achieving 25 to 30% of pregnancies.
And the
I
other thing
totally
is in any endometrial tuberculosis patients, like you put in a case now like that. In such cases, instead of doing only hysteroscopy, we can also combine with laparoscopy and clip the tubes. Or
Totally agree, Dr. Nagesh. I think, while especially when we ourselves as fertility specialists, when we do our own cases of minimal invasive surgeries, and I think it's easier when we depend on somebody, that's when you'll miss the laparoscopy, or you're doing something else. And I totally agree with Dr. Kundavi and Dr. Nagesh that I think even Cochrane supports that you don't have to wait for a beautiful lining of 8 or 9 mm, even at 6 and 7, when you have a triple line zone 3. I think it's very good. But then that caught my attention of Dr. Vidya saying, I know you should have a euploidy embryos. How many of you make it mandatory you need to do a PGTA and morphologically? Okay, fine. But then anyway, we're asking, how many of you propose PGT testing for your patients? I mean, I'm just asking. Any of you do it regularly, or what are the
Only for
indications? What are the
RPS.
cases?
We do, ma'am. We do for not for all cases, but yes, we definitely do PGT.
Do you have a cutoff if she's got two good morphologically looking day 5 embryos? She's failed. Is that when you advise, or is it one failure you ask her to do
There
for
are
PGTA?
few subset of patients, I think, ma'am, where PGTA will be helpful probably. I think increased age of the female partner is first thing, I think, where PGTA can be advised. Other than that, recurrent implantation failures and recurrent pregnancy losses. And severe male factor infertility probably, I think.
What I found in the patient, if patients are having good set of embryos, if you tell the cost of the PGTA and if you counsel them for the PGTA, it is difficult. They say, okay, instead of spending this much amount to PGTA, you put those embryos. Whenever it is good, I will get pregnant. So practically, I think they are saying the right thing, no? Because we cannot counsel them that if it is abnormal, I will discard this.
And I think it's very important that very important is the discussion, the counseling, which is very important, because PGTA is definitely expensive. So we'll have to think about, you're talking about the ICM and all these things, and you're looking at it. There has been a lot of studies which says even when you do a PGTA, it comes as aneuploidy, and it doesn't have to be a major anomaly that we have to discard the embryos. Of course, this controversy is going to be there because PGTA has just come in and then still needs a lot of these research. And while I was asking this question, I was thinking about, if you have a child with autism, first child, how many of you offer PGT testing, or do you think PGT is going to be helpful for these patients?
That specific PGTA for those genes, whatever are mutated in the parents, not
I
routine.
think they will require a genetic counseling, ma'am. I usually prefer
Counseling
to
and decide what gene you want to study.
So in such
So,
case, better to discuss.
Kundavi ma'am, Shavi, please
No,
continue.
ma'am. That's fine. That's fine. Nothing major.
The autism may not be because of the embryos or something, but what we have seen is like the elderly male persons, tend to have a slightly high risk of autistic child. We always have a genetic counseling. We bring the child and see where they stand, whether it's a mild, moderate, or severe, at what age they have identified. So goes with the past history, look at the child. I think you'll have to take a call on that.
Yeah, so I think genetic counselor is very important, which is also a part of the ERT, centers as well that you should have a genetic counselor, and autism cannot be ruled out by PGTA testing. It needs a lot of evaluation where the mother needs to be checked, and they need I ended up doing a lot of research because I don't know, unfortunately. Last month I ended up three patients on the same month with first child being autistic, so I had to really put my head, because everybody wanted to do PGT testing, and that is why they came in. I believe you're supposed to do the mother's testing first. You are supposed to match the band, and only on those testing, then you can do the PGT, because you require that particular band which needs to be done by PGT, and it cannot be done generally. And interestingly, I also found out, because one patient shifted from another doctor in between, they'd already started stimulation. And I was like, God, who shifts like this? And you've not done your research, you come in, and in between you're sitting on my head that you want to go ahead. I believe if you do a egg pickup and you've not done a mosaic, all these things, you have to freeze, do all the band screening, and then only go ahead and do the PGT testing, and not directly for this mutations, I believe.
If you catch them up early,
Yes, that is pre-stimulation. Yes,
pre-stimulation.
Some therapies would help the child.
Correct. True. Any other inputs from anybody? Yeah, that also brings us to the point when we're talking about the endometrium. How many of you believe in endometrial scratching or any other interventions before transfer? Anything that you particularly do before the transfer? The magic treatment that you get a better success rate?
I think the olden days people have said you do a DNC, people will fall pregnant.
GCSF may work. In some patients with thin endometrium, GCSF may work on the before starting progesterone.
Ma'am, okay, my personal experience, I know, we've already seen the endometrial scratching. So many studies have said that it doesn't work. But to be very, very frank, for all the patients for whom I had done a hysteroscopy for whatever reason, they have all conceived. So I think somehow it does bring about some inflammatory changes, and some changes do occur. I think it's still too early to see, but even though we don't have any evidence to it, but I think it does help to some extent in many of the women, unless they have probably some other cause, some major causes because of which they're not able to conceive.
During
So
hysteroscopy, during hysteroscopy, the distension itself will cause some.
We should not be doing for all hysteroscopies, please. I don't do for all, but for all of them whom I have done, they all actually, incidentally or coincidentally, they did get pregnant. So I definitely think there must be some correlation between the inflammation, because even in KISAR, we had one of the keynote speakers from an international speaker speaking about the role of immunology in implantation. So definitely there must be some influence for sure.
So, I'm sure we are opening a controversial topic, and that should be the next panel discussion of to scratch, not to scratch interventions before and after. And I think immunology is totally a
but
different.
the whatever scratching studies were there, no, it was in a luteal phase. So these hysteroscopies, when those are done, that is also important. If last proliferative phase or post-menstrual hysteroscopy, I don't think so that immunomodulation will help in this cycle.
Recently,
So it is better
the
to
patients with
if you want to
RAF,
scratch only. Sorry.
patients of RAF, Lavanya, if started using thymosin, what I've observed is like they get endometrium, the endometrium grows faster actually, very surprisingly. I'm just yet to get complete my studies, but what I've found is like endometrium also becomes thicker with the thymosin.
We had a talk in the recent KISA. I think this is something to wait and watch. If it is going to help us get a better endometrium. Any of you been using it? I've not used it.
No, I have not used.
Dr. Nagesh, Dr. Santosh, Chandana, Shaviz, any of you? Satvik, Sujay?
No, ma'am.
Even we have not used. I think Kundavi ma'am will wait for your papers also, and maybe we have more to learn from that. And I think it's something new, and we have to wait and explore. So, Dr. Rashmi,
Yes,
any
ma'am.
endometrial receptivity testing? Any of you do ERA on regular basis?
Not regularly.
No.
Some patients, if more than 3 morphologically normal embryos, If I failed, I have done ERA, and whoever patient I did ERA, I got positive results. 5 patients I did, 4 patients I got positive. One patient, it was late receptive. She was advised repeat biopsy. She has not come for biopsy.
Anybody objecting to the ERA, or all of you agree with the ERA?
I mean, there are controversies regarding the ERA, like, whether we should do or we shouldn't do it. We have done because running a fellowship program, but it helps you for a personalized transfers depending on the test.
If there is nothing to answer the patient only will come. I
Yes,
want to
totally.
do this.
Totally agree with Dr. Vidya and Kundu ma'am. Yes, I totally agree. Especially when we have a very good lining, we have good embryo, we have day 5 embryos, even the lining looked beautiful and they still didn't, implantation didn't happen. I think these are the patients that we can think of ERA, and they would definitely be, more, better results. Dr. Rashmi, sorry, Dr. Ramesh, yes, tell me.
In such cases, in repeated implantation failures, when there are good embryos, good-looking embryos morphologically, so when we plan for ERA test at the same time, I think embryo biopsy also needs to be done.
Correct. Totally agree. Yes, I think PGT we had touched upon. Yes, totally agree with you. Yes, both of it. I think it's a choice that is why counseling plays an important role. While we talk about it, costing needs to be considered. These are the options that we can give our patients, especially they are definitely going to be unhappy with the results, and I think these are the options that we can offer and conclude with the conclusion and counseling of the patient. Take a call on what is best. Dr. Rashmi, I would like you to conclude on these points.
Yes, ma'am. One practical input I wanted from everybody, that what are your favorite progesterones or the routes that you prefer? Do you prefer only one route, 2 routes? Because I see a lot of patients having gel, they have injections, they have capsules, and they're loaded with progesterone, constipated, and nausea, vomiting, and whatnot. So I would like to know from each one of you that what is the mode that you would prefer, and is there a single mode or the 2 routes that you prefer?
No, because there may be a compliance issue. So when you give a micronized progesterone vaginally, we add 50 milligram or 100 milligram of injectable progesterone. Yeah.
Every third day, twice in a week.
Yes.
Let everyone tell their protocols.
Yeah, because of compliance issue, we can add difeston or
Oral
dydrogesterone
also.
or IM progesterone if patient is willing. But I don't give daily. I give every third day. At
Now
least mid-luteal phase we should cover with good progesterone.
See, the hydrogesterone, there was a lot of studies, fresh versus frozen. I think the Lotus comes with the fresh.
Lotus
When you're giving a dydrogesterone, probably we may need to add another drug as well.
Because now a subcutaneous injection have come, I have not used. I'm still using oil-based only. I would like to ask the panelists, like your experience with the usage of subcutaneous.
I have been using it. The dosage comes down. It is only 50 and works quite well. Had good success. Especially these are patients who complaining. You have your little sophisticated patients who are not going to budge using your IM at all, and they're like, even IM gonadotrophins, no for them. It's like everything they want subcute, and this is how they want, and they start coming to you asking, "This is what I want." So we have staying in metropolitan cities. I think these are the patients we get.
But the aqueous progesterone, what milligram comes in a 2 ml formulation. So it is very difficult to give.
Difficult, but then the patients are very
2 ml
happy
they have
with
to
that.
take.
Yes,
Yeah.
they're more happy.
It is as far as I am only, but you should give 2 ml subcutaneous.
Yes, ma'am. There are a lot of patients who have the needle phobia, and some are not comfortable having vaginal insertions also. So it gets difficult to counsel them in that scenario. So any other routes or compliances that you counsel them? Other panelists, any inputs?
Dydrogesterone and vaginal progesterones.
Vaginal progesterone and IM progesterone are the best.
So also I just had heard in one of the other conferences, and I've also some of the patients who have extreme vaginal discomfort because of these progesterones, vaginal progesterones, you can also give them per rectal progesterone, the same one, because some of them who had a lot of trouble, we did switch over, and there was like absolutely no effect on the pregnancy or increased rates of bleeding. So that is also a safer route, although not the preferred one. But if somebody is not able to tolerate vaginally, we can supplement the same thing rectally as well.
I think the rectal suppositories are very excellent because they have a targeted therapy even compared to a vaginal one. I think earlier we were using, but because I've been trained by Dr. Verma who had come from UK, because I think in UK earlier people were using the rectal suppositories. But in an Indian scenario,
Not for all, ma'am. Only for those who can't tolerate it, like they have extreme amount of vaginitis.
Definitely you can try rectal suppositories.
Yes. And one more practical point is, I think we should ask them whether they're inserting it deep inside or not, because it's just at the superficial, then definitely they would feel irritation or they come up having discomfort. So we should make sure that they are inserting well deep enough so that it has its effect.
Actually, I think it's a beautiful point, Dr. Rashmi. Yes.
When we are using gels now, so that gel is having some carrier, maybe, I don't know. So when you give BD or gel to the patient, and when she has brought a cotton ball with of that gel from the vagina, I
Which
did
is dark
speak to them,
colored.
and it was like then that time I was using Crinon gel. I discussed with Merck company that this type is happening. So they said that you should ask the patient to clean these things regularly. Otherwise, it will accumulate because it is along with that drug. So these things should be told. Otherwise, the patient will be having infections and all other problems with all the vaginal preparations.
I give intramuscular progesterone, old and trusted.
Yes.
Yeah, yes. But if you do MNC cycle, only 2 days in a week is enough. Intramuscular.
Your daily. Till pregnancy test is positive, and after that I may little bit shift here and there.
Yes. But the gel and progesterone, I have seen that ball. I had photo. I had sent to that Merck also that this type of thing have come. What to do? Then only I understood it is because of gel.
This sort of a muck formation, I've seen it with sildenafil when you use it, no?
Yeah.
At least now you have the vaginal one which gets dissolved. But otherwise, earlier one, like you'll have to wet and then keep it in the vagina. They form a muck at the vagina. To clean that during an embryo transfer was quite difficult.
Yes.
Dr. Lavanya?
Yes, I agree. Yes, the time's up, and I think we had wonderful panelists. Thank you, my co-moderator, Dr. Rashmi, who's put in so much efforts to make the slides. Thank you, Dr. Rashmi, and beautiful discussion. Thank you, all my dear panelists, for an interactive session. Thank you, conveners, Dr. Anu and Dr. Seema, and our Ksoga team, Dr. Durga Das, Dr. Shilpa, Dr. Shobha Gudi Madam. Thank you so much for this wonderful opportunity. And I think it's a great academic way to discuss, and all of us coming together on this platform. Thank you. Thank you, my dear panelists, all of you. Thank you,
Thank you, Lavanya.
Thank you,
ma'am.
Karnataka team, for
It
helping
was a
me,
wonderful
taking
program.
me. Yeah.
Thank you, everyone.
Thank you,
Thank you,
Kundavi
thank you,
ma'am, for
ma'am.
making time and joining the Karnataka team.
Yeah.
So
Thank you, Dr. Shilpa.
I'll give the
Thank you,
formal vote of
Dr.
thanks.
Kundavi. Thanks for joining.
I
Thank you,
thank
everyone.
everyone. I thank everyone, the speakers, the chairpersons, the panelists, the moderators, the experts, and our chief guests, and all the office bearers of Ksoga, and especially our president, Dr. Durga Das. And we should not forget our partners, Corona Remedies, who have given us this beautiful platform, and they have been extremely nice and helpful, and how many times we change the flyer. And I hope we have such beautiful interaction again and again. And Dr. Shilpa, I want to end this session by saying something.
Yeah, thank you, everyone. That was a wonderful program. It is a good start for all of us. Looking forward for many more in the future. Thank you, everyone.
Thank you.
Thank you.